Good morning, YouTube. I am going to get Instagram up and rolling. Good morning, PT on Ice Daily Show. My name is Dr. Ellison Melrose. I am faculty with the Dry Needling Division of ICE. I am here to talk to you guys today about dry needling during pregnancy. We're going to talk about 3 reasons not to dry needle during pregnancy, 3 areas to avoid during pregnancy, and then 3 reasons to use dry needling with e-stim during pregnancy. So that is on the agenda for today. Before we get into that, let's talk about some of our upcoming courses for dry needling. We are going to be in Roswell, Georgia, the first weekend in June, so June 2nd through the 4th. We will then head to Baton Rouge, Louisiana, and we'll be there June 9th through the 11th. So those are both upper extremity courses. And then in Berryville, Virginia, June 23rd through the 25th, that is going to be our next lower quarter course. So if you guys haven't, if we haven't seen you out on the road yet, there's plenty of courses the rest of this year to hop in, but we are already booking out to next year. So awesome. So dry needling during pregnancy. So some of you guys may have seen me previously on this podcast on Mondays. I was previously with the Pelvic Health Division of ICE. And then once dry needling became a thing, I asked if I could be a part of it. So I'm super excited to be here with you guys today, blending my world of pelvic health and dry needling. So common question that we get on the road is, what about pregnancy? What about dry needling during pregnancy? What is allowed and what is not allowed? And so I'm here to kind of answer some of those myths for us today. So let's start off with 3 reasons why we wouldn't want to dry needle during pregnancy, because again, this is something that we want to be aware of. First thing that we want to consider is, where are they in their pregnancy? Oftentimes we have been treating a patient a long time and they come in and they tell us they're pregnant. But typically what we recommend is that avoiding dry needling during the first trimester of pregnancy. So it's going to be 0 to 14 weeks of pregnancy. And the reason why is not that there's any literature support that dry needling would be cause for miscarriage or anything like that. But what we don't want our patients to associate is anything that they could have done that had caused a miscarriage. So as we know, miscarriage is fairly common. Between 20 and 25% of women experience a miscarriage in their lifetime. But what we don't want them to do is blame themselves for anything that they had done. So dry needling being one of those things. So does that mean that if, again, it's this patient that you've been seeing, treating their headaches for 6 months with dry needling monthly, and they come in and tell us they're pregnant, does that mean that we're going to just say, nope, we can't do it? Not necessarily. So this is a conversation to have with your patients and kind of discussing the reason why we typically don't dry needle during pregnancy, and if that's something that they would feel comfortable with. With that being said, there is a patient population that I hold a little more firm of a line with for dry needling during pregnancy, and that's someone that has had recurrent miscarriage. So if they've had recurrent miscarriage, the last thing I want to do is, again, have them blame themselves for something that they did during that early pregnancy period. So typically for those clients, what I will do is I would recommend waiting until their anatomy scan. So 20 weeks is typically when we have our anatomy scan, and that is also when the likelihood of miscarriage drops significantly. So their anatomy scan will make sure that everything is in working order and where it needs to be. And at that point, I would feel a little bit more comfortable dry needling. Again, does that mean I never have dry needled someone that has had a miscarriage? No. That means I am, again, taking the patient in front of me and discussing those options with them. The last reason to not dry needle during pregnancy would be if someone has never been needled before and or they have a needle phobia. So it's typically not my first line of defense if someone comes in during pregnancy with any sort of musculoskeletal injury. Usually, first line of defense is going to be something movement based, right? So, exercise, motion is lotion. We want to get these patients moving, especially if during pregnancy they have maybe become a little bit more stationary. So, first line of defense is never dry needling. Again, does this mean that I'm never going to introduce needling to them later during our plan of care? Not necessarily. There's going to be a lot of education around. I believe dry needling is one of the most efficient things we have in our toolbox to reduce musculoskeletal pain. And so that is something that I will broach with them eventually, but not typically first line of defense. Okay. Next, we have 3 areas to avoid during pregnancy. The first 2 are pretty self-explanatory. The first one we're going to avoid is needling the pelvic floor. So the pelvic floor is something that we can dry needle and can be a very efficient tool for people that experience any sort of pelvic pain, any pudendal neuralgia type symptoms. But during pregnancy, we want to make sure that we're not getting that needle anywhere close to the uterine wall as to avoid any interaction with that muscle layer that we don't want to stimulate into contraction. So pelvic floor is the first place that we would want to avoid. The second place, for similar reason, is going to be the abdominal wall. So if we can think about how that uterus is changing over the course of pregnancy, typically before 20 weeks, that uterus lives below the umbilicus or the belly button. And so we often may think that it is, a safe area to needle, but I typically would still recommend avoiding the abdominal wall during pregnancy. For some of my athletes that maybe I am treating for bladder dysfunction and they are in, an earlier stage of pregnancy, it may be something that we again discuss and talk about. But typically what I would say is abdominal wall is not an area to treat during pregnancy. The last is going to be the thoracolumbar junction. And this is because that sympathetic innervation originates from T12 to L1 spinal segments through, so we want to make sure that we are not doing anything to stimulate the nervous system, which would then increase the likelihood of preterm labor. So we want to make sure that these moms are making it all the way to 37 to 40 weeks and a smooth delivery. I have tried to self-induce by needling the TL junction once I hit 37 weeks, and I will say I was unsuccessful. So there's not a ton of research out there right now on if we were to cause preterm labor by needling the thoracolumbar junction, but there's never going to be research here. So what we want to do is, again, avoid areas of potential interaction with the uterus there. So those are the 3 reasons to avoid, 3 areas, to avoid needling during pregnancy. The last that I want to touch on today is 3 reasons to use dry needling with electrical stimulation in general, but particularly during pregnancy. There is extensive literature support the safety of electrical stimulation during pregnancy. One area that is commonly discussed as an area to not needle would be, use e-stim, would be anything that kind of surrounds the uterine area. So we can take this to consider the lumbar spine as being one of those regions, as that if we had electrical stimulation with the pads, we would want to make sure that that is not, again, interacting with the uterus through the electrical current. What I would say with dry needling with e-stim is that it is an indwelling needle with e-stim is much more precise, a much more precise application of e-stim than transcutaneous. So that would be the sticky pads, transcutaneous e-stim. So indwelling needle would likely be a better option than just transcutaneous e-stim. And it is completely safe to do this in the lumbar spine during pregnancy. Another reason to use e-stim with dry needling, not as only is it a very efficient way to reduce pain in our patients, but it can also improve neuromuscular recruitment and force output. So as we consider our patients who are going through pregnancy, their anatomy changes significantly over a course of 9 months, right? And so what we often find is the length-tension relationship of those muscles and ability for them to produce force changes over time. For example, glute max, right? We end up, our patients end up in this significantly lordotic position, and the glute max can be something that's often on slack and we're unable to recruit it as efficiently as we were before. And so that would be an area, the glutes in general would be an area to improve muscular recruitment, particularly in someone that has pelvic girdle pain, which is a common complaint during pregnancy. So I would say that we can improve those muscles' force output, but remember that that is just a window we have. So dry needling with e-stim gives us a window of opportunity to then use those muscles and strengthen them more post-treatment. So always end our dry needling with e-stim and try and apply that with a load that they can tolerate. So that is another reason to use e-stim during pregnancy. And the last would be e-stim with dry needling can significantly reduce post-treatment soreness. And so if someone during pregnancy is coming in and are maybe unable to move the way that they had in the past due to pain, the last thing that we want to do is send them home with like significant pain for 24 to 48 hours, right? And so some other dry needling techniques, including pistoning, may be a little more of an aggressive form of treatment. Not that I never use pistoning in my practice and I never use pistoning with my pregnant patients, but I have found clinically that using e-stim can be a very effective way to get the treatment and stimulate the nervous system without significant post-treatment soreness. So those are the main 3 reasons to try and apply dry needling with e-stim during pregnancy. So let's do a recap of what we talked about today. So we talked about 3 reasons to not needle during pregnancy, those being needling in the first trimester. Again, we want to just have that conversation with our patients. The second is someone that has had recurrent miscarriage. Typically for those clients, I would wait until their anatomy scan or 20 weeks of pregnancy where that rate of risk carriage drops significantly. The third is if someone has never been needled before or they have a phobia of needles, it's not going to be my first line of defense with my apprehensive patients who are pregnant. 3 areas to avoid during pregnancy are going to be anything that we can kind of interact with that uterus, right? So we have the abdominal wall, the pelvic floor, and then that thoracolumbar junction. 3 reasons to use dry needling with e-stim during your practice is that it is safe and effective, especially with an indwelling needle where it is super precise. Next is that it can improve that neuromuscular recruitment and force output of our muscles. So we want to use that and then take that and use it with exercise after treatment. The last is that it can help decrease post-treatment soreness, so we can get those pregnant patients feeling less discomfort than with traditional or dry needling alone. e-stim can reduce that post-treatment soreness. So I hope you guys learned a little bit today about dry needling considerations during pregnancy. I will be on the road coming up if you have any questions about that. I will also be doing a follow-up podcast in a couple of weeks on dry needling during the postpartum period. So yeah, I hope you guys have a great rest of your Tuesday, and I'll see you later.